Good afternoon, ladies and gentlemen. On behalf of the Vicenza Health Center Commander, I welcome you to today's Community Town Hall meeting to discuss the space available services provided by the Vicenza Health Center. Upon the conclusion of Colonel Barr's opening remarks, a microphone is located on the far wall if you have a comment or question. For those of limited mobility, please raise your hand for the wireless microphone. Now for the opening remarks by Colonel Barr.
All right. Hey, good afternoon, everybody. Appreciate you showing up, and for those that might be viewing over AFN. Significant amount of capacity to basically take care of our entire community, and there have been some changes to that recently, and I'm going to go through all of that. Before I get started, again, like I did this morning, I'd like to thank our civilians, first of all. So without your support and without your service, we would not be able to continue on as an Army. I do know that specifically over at the health center, we would not be able to get our daily jobs done without all the great civilians that we have working over there. So regardless of things that we'll talk about today, we value your service, and we are all in this together, although when change comes, sometimes it does not seem like that. I also personally apologize for the abruptness and possible confusion that came out when our changes got posted on Facebook. That was my responsibility. It was something that I had to do very quickly based on some situations that occurred that we'll talk through this morning. So for any hardship, anxiety, confusion that caused, I do apologize for that, and we'll move forward together with that. Bottom line up front, my intent has been and will continue to be to guarantee healthcare access for our TRICARE beneficiaries and to maximize the amount of additional care that we can provide for our community. And so we'll talk through that a little bit here in just a second. All right. So the mission of the health center here is to take care of soldiers and their families. I am, and my staff at the hospital, at the health center, is guided by we have to provide care for our TRICARE beneficiaries. That is the one thing that we have to do, and no mission can come before that. We're governed by certain regulations, both through DoD, MedCom, European Regional Medical Command, Landstuhl, and we have constraints that we have to live within to provide care for the community. I think the best way to look at the space available care situation is to look at it through mission and constraints. And what we've experienced here in Vicenza over the last year or so is a significant increase in our TRICARE beneficiaries without an equal increase in staff to take care of them. And so what has normally been a ton of space available care, that is starting to whittle down as we continue to try to take care of our TRICARE beneficiaries. The other thing, I had a slide up this morning that talks about priority of care, and that's really where we need to focus on. Because again, what we're going to do is try to ensure that we have enough care daily for everyone, but there may be days that I can't guarantee that. One of the issues that led to us posting what we did on Facebook and having to reevaluate some of our programs was 3 weeks ago we started to become aware that our TRICARE beneficiaries were calling in first thing in the morning, getting put on hold, and then not getting an appointment. And we looked into that and said, well, why is that? We looked internally, and some of the internal processes that we had needed to be revamped. We have to ensure that we've got provider availability every day. We've got to ensure that our templates for how many appointments that we have every day is at the maximum. And once we've gotten that fixed, which we have, now we have to look at how are we giving that care out. And what we found is, since there were no rules in place to try to better segregate the priorities of care that we were having our Space A patients calling in at the same time as our TRICARE beneficiaries, and they were basically competing for appointments. And so once we corrected that with the email message that went out on Facebook and with some of our practices, that situation actually rectified itself. In that week that it was between the two messages came out, we have been diving into this issue. I've talked with all of our providers, with our nursing staff. We've tried to identify how can we best go forward to continue to provide care for our space available folks while we are ensuring that care for TRICARE beneficiaries, and I think we've got that. Going through the priorities of care, just for those of you who may not be aware of it, our first priority of care always will be active duty. So if I have to deploy half of the clinic, which is not going to happen, but if I have to deploy half of the clinic and we only have enough providers to take care of a certain population, I have to make sure that my active duty gets taken care of first. Since that's probably not going to happen, I then have to focus on my active duty family members and my retirees. And my retirees will be enrolled in TRICARE Plus overseas. After that, we go to active duty family members that are not enrolled in our clinic in Prime. That may be spouses that have decided to stay home while an active duty spouse is performing service overseas and come and visit for the summer, or that kind of thing. That's our priority 4. And then our retirees that are not enrolled in Plus. So I've got 5 priorities of care that I have to make sure I take care of before I have any space available service that can be provided. And when you go back and just do the numbers on that, that care is very limited. And unfortunately, because I cannot guarantee care for non-TRICARE beneficiaries, we start getting into discussions of how are we going to provide that care, and we'll talk about that here in a second. All right, so some of the things that have not changed. There have been rumors out there that we're not going to see civilians anymore and we're not going to take care of you down at San Bortolo. That is not true. So again, as I have space available to provide care in the clinic, those appointments will be made available at 11 o'clock now to where our civilians can call in, and whatever space available we have left in the day, whether it's 1 appointment or 40, the community can have those for acute care needs. Also down at San Bortolo, where our patient liaisons are, those patient liaisons, again, are down there to take care of TRICARE beneficiaries. And so if I have 2 TRICARE beneficiaries in the emergency room, and I have 2 patient liaisons down there that need to take care of them, then those 2 patient liaisons have to take care of those TRICARE beneficiaries. If I have a Space A patient that walks in and also needs care, unfortunately I can't provide that care because I'm performing my primary mission. However, if I have 2 patient liaisons downtown and only 1 patient and a Space A patient comes in, obviously we're going to help take care of you. So that has not changed. Our pharmacy will continue to accept Italian prescriptions. We have some literature that we're going to be putting out today to let you know if you receive care in the, on the economy, what needs to be on that prescription for us to just be able to receive it. So we will be able to fill those prescriptions. That's based on the European Regional Medical Command pharmacy formulary, and then also some other rules that we'll have on that page. I think it's well known all civilian employees must carry third-party insurance while you're over here. And even if I can provide you space available care in the clinic, there may be a time where you need to go out and be hospitalized or see specialty care, and that insurance that you carry is what covers that. The things that have changed. So again, we put out on our Facebook that 12:30 was the time that you could call in. Sorry, I'm sweating like a dog here. Let me take care of this. 12:30 was going to be the time that you could start calling in. That's going to be 11 o'clock now, and that is a moving target. So we're going to continue to look at that. If I can move that further to the left to make that more convenient for our civilians, we'll certainly do that. But again, like I said earlier, since we've made that change, we've actually rectified the problem with our access for our TRICARE beneficiaries. Probably one of the biggest things that we'll need to talk about today is the management of chronic medical problems. Now, I'm a family physician. And I would tell you that we have a large number of civilian employees that are over here that have significant chronic medical issues. And that's not necessarily a bad thing, but the best way to deal with those things is with a primary care manager or with a doctor that you see routinely that knows you, that you don't have to keep explaining your medical history to and your surgical history and that kind of thing, that can make a diagnosis, give you a treatment, get whatever labs and x-rays you need, and then you have guaranteed follow-up with that person. That is something that, based on Space A, I do not have an opportunity to do. And probably a large percentage of our Space A folks that come in, probably up to about 500, I'm guessing, in the community, have accessed us for ongoing chronic medical issues. From a physician's perspective, that is not the best way to receive medical care. And so what I want to do is I want to work with the community to provide the acute care, the daily care that comes up, cough, cold, any symptom that might come up on a daily basis, but not manage those long-term problems with you, because again, I can't guarantee you're going to come back in and see me for that same problem. A couple of the other things, housekeeping from this morning, telephone consults, will not be able to take those because again, since I cannot give you a primary care manager, I don't have someone to hand a telephone consult off to manage your care. Certainly if you have come in to receive care on an acute basis, and we've drawn some labs or done some x-rays, or we need to follow up with you, we will certainly utilize that to call back and forth to you until we've resolved that issue. But again, folks calling up trying to get refills on meds or trying to handle a chronic problem through the phone, again, is not the best way to practice medicine. Again, the information sheet that we'll be sending out today, so if you do see an Italian provider, we can get the appropriate pharmacy information on. That will be the way that we make it convenient for you to get into the pharmacy. We're not going to be able to have you bring prescriptions in from an Italian provider, come into an acute appointment, get all those transcribed, and then put into the pharmacy. Because again, that forms a contract with us on saying, I will manage your long-term medical conditions, and that's not something we're going to be able to do in space available format. There's a current practice downtown at San Bortolo where our patient liaisons have been receiving medical records in Italian and translating those medical records. This is a whole other issue, as I explained this morning, that we're dealing with our TRICARE Overseas contractor. Our patient liaisons really should not be in the business of translating records anyway, and so we're working that issue. However, I'm not going to be able to do that for space available patients. Again, that's something that if you're hospitalized, that's between you and your insurer on how that insurer wants to get those medical records back for payment and for long-term care. And then referral management, again, will not be able to make appointments going out either, because again, we're not managing chronic issues. The good news with that is that we have been able to develop a listing of providers that are on the economy that we're going to be sending out later today or tomorrow to the entire garrison, to everyone, so that you'll have a list of English-speaking providers, 10 of whom are family physicians, one of whom who's a pediatrician, and we will continue to refresh this list as we either get feedback from the community or our referral management team finds other availability out there, and that's a service that we definitely want to provide to help make transition easy. The other thing, really the main thing, two big things here at the end. If you are a retiree and you are a GS civilian and you are not enrolled in TRICARE Plus, I highly recommend that you enroll in TRICARE Plus. If you enroll in TRICARE Plus, then you become a Priority 3 patient. I can give you a PCM. I can pretty much guarantee you access to every service we have in the health center. So I know that is just a small percentage maybe of folks that we have here that are not enrolled in that already, but that's one way to help mitigate for a small fraction of the community how to get in for health care routinely. And then the other thing, the big thing with the chronic care piece just becomes, how do we transition for that? So we're not just going to say, all right, hey, here's the new deal and you're done, go have fun out on the Italian network. We've got some data calls into Launch Tool right now. We're trying to identify those patients that we've seen at the health center at least 3 times in the last year, which would indicate to me that you're having some chronic medical issues that we're following you for. And we are going to reach out over the coming months, probably the next 90 days, and coordinate with those patients to coordinate that transition of care to an Italian PCM. That may involve an additional visit at the health center with the provider that you've been seeing. That may involve printing of records and refilling of medications and last-minute lab work and those kinds of things. But that's something that I definitely want to do to help with this transition. Establishing with an Italian physician who speaks English as a PCM is not a bad thing. It's actually a very, very good thing. And what I encourage our Space A folks to do is go ahead and make that establishment so that you have that in your back pocket. If you don't have any chronic medical issues, then again, you can call in every day at 11. If we've got space available, we'd be happy to see you for whatever's going on with you, and we'll take care of you that way. But in case I can't get you in, or in case you do develop a chronic issue, then you'll have that kind of lifeline out onto the network, and you'll have a good PCM that you can establish care with and manage your medical issues. A couple of other things that we're going to be sending out to the community. I already spoke about the Italian physician list. Another is an info paper that was written by the Launch Tool PAO that kind of talks about access to care standards throughout Europe. It's about an 11-page document. It's real good reading. I'll send that out as well. And then again, the prescription requirements that I talked about earlier. There are a couple of special groups that have come up to my attention, both from my staff in the health center and also from the community, that there's significant concern about. One of which is our babies, our pediatrics cases up to 2 years. So as you know, we have a birthing center which will be closing down in the middle of June, and we are still providing obstetrical care both to enrollees and to Space A. We have no issue with capacity there, and that's not a service that will change. But those children obviously need to be followed up very regularly early on, and then every 6 months after the first 6 months. So we're working out a system where we can figure out how we can provide that care. Whether that's increasing appointments or being able to schedule out a little bit further. There is a little bit of a difference between the Italian immunization schedule and the American immunization schedule, and what we don't want to do is set anybody up for failure later as you're trying to get into CDC or into a school and having to get you caught up at a later date. So our pediatrics department and our DCCS is working that right now to see how we're going to do that. The other thing is school physicals, which will come up this summer. Last year and the year before, I believe, we were able to handle that load just through routine appointments. So we will look at doing that again and again, making that an area where all of those appointments are space available. If we need to, we will support the community by having an additional clinic day to get that taken care of. So that's important for us as well. I am quite sure there are other special groups out there. Some may come up today, some may come to us through other means, but as we receive that concern, we'll certainly look into that for each of those groups and see if that's something that we can provide care for or not. And that is that. So again, I very much appreciate how hot a topic this is. Has nothing to do with me sweating up here. I walked over. I do appreciate how big of an issue this is for the community. I think if you asked anybody at the health center, we would very much like to guarantee that we could provide care for the entire community. My concern with that as we go forward is I think it's just setting us up for failure, and what we need to do is just kind of restack based on our priorities and based on what our mission is, and then, like I said earlier, just provide the maximum amount of care every day we can, and I think that'll take care of the vast majority of issues. So with that, we've got a microphone over to the side for anybody that wants to get up and ask any questions, bring up any concerns, and if I don't have the answer today, we will take that back and get you an answer.
I have a couple concerns, I guess, kind of about the prescriptions. I know you're going to be sending something out on that. But one of my bigger concerns is if I go to an Italian primary care physician, I know that what the medicines available in Italy are often different than they are available in the States. Sometimes they're the same, sometimes they're different. I know one of the medicines I'm taking isn't available in Italy. So will Italian doctors write prescriptions for things that aren't in Italy? And I mean, I can bring it here and get it filled potentially.
Right.
But right now I use mail order prescription service, and my mail order prescription even sometimes refuses the prescriptions coming from the health clinic. So, and then I have to call them and explain that, yeah, it's coming from Italy, but it's a US base and whatever. So I know that they're not going to want to take Italian prescriptions, but will an Italian doctor write a prescription then that they don't even have in Italy?
Let me take that question back. I don't have a good answer for you right now on that. Utilizing mail order, you really have to almost work with your insurance company to see what they will take.
Right. I know you're saying that, you know, potentially you'll take Italian prescriptions, but I'm worried that the doctors aren't going to write for something that they don't have, you know,
Yeah.
in Italy, that they're not familiar with. Like, I can take it in and say, hey, I use this, but
Right.
are they then going to write a prescription for that?
Right. Unfortunately, I really don't have a great answer for that. I mean, I think depending on what the issue is and what provider you need, you know, we certainly need to probably find you the most specialized provider there is there who would have more familiarity with it and then could let you know. You know, pharmacies are pretty much, there's different name brands and things, but medications are kind of the same globally. They just kind of come in different names. And so it might just be an issue of getting in with a provider and saying, here's my condition, here's what I've been taking, what do you have that is the same or similar? Yeah. It also might be that instead of getting it filled through the American pharmacy, it might just need to get filled through the pharmacia.
Right, and I tried that before, and they don't have it.
Okay.
So that's what I was wondering. So.
Okay.
Okay.
If you want to wait after, I'd be happy to.
Okay, well, I have to
Hear
go
what
back
that
to
is.
work because
Okay.
I work full time.
Okay. All right. Thank you.
Hi, Colonel Barr.
Yes.
Hi, my name is Buddy Levitt, and I'm representing the teachers of the elementary school. And first of all, I've never had a problem myself of the 5 years I've been here. And I am a Army brat, born and raised at Fort Lee, Virginia. And a lot of us here, I wished if we could invite you to the school, and if you could do the same discussion and talk with the teachers, because this is not the best timing for
Sure.
teachers. If you could come and visit with us and give us the same talk and speak to us in the same tenor that you're speaking now, I think this would lessen a lot of the problems that we're having. We had this discussion last year in January where all of a sudden we got real tense about the same thing, because we did end up hearing all the rumors, and you know, rumors do fly faster than the truth. But if you could possibly come and speak to us about that with the feelings that you've given here, because many of us as teachers, like myself, I've been in the system for 26 years. I only went a few years without an ID card after I got out of college, and I've been part of the military. I am part of the military still, and that's one of the things that, even though I know I'm not priority, but I still am priority.
Right.
Because when I go to the clinic, I have never felt as though I'm one of those.
Right.
I've always felt as though I'm, you know, part of the family, because that's what we are. We are the family here. We even though I am civilian, being a teacher, we are family, and we all, you know, that's how it is.
Right.
And when I call up, I think sometimes it's whoever is on the other line and says something, and they may not say it in the correct way to the person that's on the phone that needs that appointment. And 11 o'clock is far better than 12:30, but 11 o'clock is not really best when you are a classroom teacher trying to figure out a time to call. But we went through that before. But I would just like to invite you to the school to be able to talk with us after the after school hours, and just be able to maybe bring some of the liaisons from the school also.
Sure.
I mean, you know of a situation that happened with a teacher and her child that's at the San Berlo. You've probably brought that, and I won't bring that up now, but there was a situation last week that wasn't in the best interest and it wasn't handled, but thank goodness y'all did send liaisons there to help and make sure everything's going better.
Yeah.
Okay.
Well, first of all, I'd be happy to come speak at all the schools. That's not a problem at all.
Okay.
We'll just have to get that scheduled. I'd be happy to do that. And we are one big family, and I think that's why it's very difficult for any of my folks to sit in here, just as it's difficult for me to sit here and have these conversations with you, because I think we do all consider ourselves one big community. I've got 2 kids in school, so I certainly appreciate what our DODS teachers do. So I'd be happy to come by and do that. I'll get with
Okay.
leadership later, and we'll
Okay.
get that scheduled.
Thank you.
Thank you.
You don't get away without having to hear from another teacher.
Excellent.
I'm Colonel Barr. I'm Lori Vallone, and I teach your daughter at the middle school.
Very good.
Uh,
How's she doing? Okay.
she's a great kid.
I'm always checking.
She's a great kid.
She is a great kid.
Anyway, I have questions from my teachers that I brought with me, so I'm just going to kind
Sure,
of try
go
to go
ahead.
through the ones that I didn't think were answered. Again, I can be with Mr. Levitt. I don't have these issues because my husband's a retiree. So for me, it's all great, and I could leave and forget it. But I represent the teachers, so I need to bring this to your attention. One of our teachers tried to make an appointment several weeks ago, and she couldn't, so she called 5 different Italian doctors, and they couldn't see her either because they kept directing her to sign up for the EU system, the medical card system, and we can't sign up for it, and they wouldn't see her without it. So that was a problem. She never could get an appointment, and during that time she called every day at 12:30 like she was directed, and for a whole week couldn't get an appointment for her child. So her child was very sick and couldn't be seen either on the academy or at the
health center.
clinic. So
Yeah.
that was a problem.
Okay.
Um,
So I'll just answer these as you're going along. So again, I take full responsibility. We did not have a good list out, I think, when I made that decision last week, and I'm quite sure that caused a bit of consternation. I think we do now have a good answer, and like I said, I'll get this out today, and we'll get that to everybody. The EU card, we're gonna have to look into that. You're not talking about the Codice Fiscale?
no, it's
Okay.
a medical card.
Okay.
That
'Cause
they, medical.
yeah, but you shouldn't have to have that. So.
You can't have it.
Right.
You will lose your job if you get one.
Yeah,
Right.
Because you
so-
will then, that's a step to becoming ordinarily resident,
Mhm.
which will then disqualify you from being a civilian employee.
Yeah.
And
You cannot get it. That message also should go out. Do not apply for this.
yes, because some doctors won't see anyone who doesn't have that. They won't see paying patients. So
The physicians that are on the list that we're going to send out have been vetted by our referral management, both to identify if they have capacity for new patients and if they do speak English and that kind of thing. We didn't ask this question, but I'll go back to Elizabeth and have her ping each of these providers, and just to make sure that's not a requirement, but should not be. And again, one of the other concerns that typically comes up from our civilians is, I have to pay out of pocket to go outside of the health center. So these places on this list, I would expect you're going to have to pay for the visit and then file that with your insurance, but it shouldn't involve any kind of card or anything like that.
Okay, the next question comes from our school nurses and counselors. Many of our students are on medications. They may have civilian parents, they're on medications, they have diagnoses such as ADHD, and they're on 504 plans and IEPs and other types of things. And in order for us to take care of their needs at the school, other medical needs have to be taken care of and communicated to us. So how will that be handled?
That is another one of the groups that we're looking at. How are we going to manage? So I'm discussing that with Colonel Burnett and Colonel Major Lemjuco right now. We are aware of a significant population of patients of different classes that may not have the same service out on the network. So we're looking into that.
Okay, and this is the last one, I believe. I have a faculty member who is a young man who is being seen at the Mayo Clinic, and he has some particular needs, and he needs to be followed up by a physician that can communicate regularly with his physician at the Mayo Clinic to adjust medication and so on. I think that would be a little difficult with an Italian physician, so is there something that can be done about those types of circumstances?
Yeah, that's one of those I'm going to just have to get with you after and get the particulars on.
Okay.
I mean, again, I think we may have onesie, twosie cases out there. Again, the fallback, and I know this doesn't apply to civilians, but before active duty come overseas, there's an EFMP process. And so if you have family members with very significant medical issues, you may get to go to launch stool, but may not get to come to Vicenza. There's nothing in place for civilians that I'm aware of that does that as well.
Right.
So what ends up happening is you come to a place where we can't guarantee you care, and then we have very significant healthcare issues, and then we're all kind of left trying to figure out how we're going to deal with that. So
that's not always communicated when we're accepting the jobs, just so you know that.
Yeah.
It's not the same for the civilian side of the house as
Yeah.
it is. I've been on both sides now,
Yeah.
and I can tell you it's not communicated on the civilian
I think it's a
side.
great point that you bring up. Actually, as we've kind of been wargaming this thing the past week and discovering all of these issues, there are a number of issues that really need to probably be brought up to a strategic level to say, hey, we're feeling this here. It's probably being felt elsewhere. What are we doing about it policy-wise across our government to make sure that we're taking care of our Americans that are working overseas? So that's one of those issues that we've already identified that might be good for me to push up through my chain of command.
And just let us know, we're great letter writers if
All
we
right,
need to
very
write
good.
letters. Thank you.
All right, thank you.
Hi, sir. I'm Stephen Salerno with the JAG office. I have a few comments. First of all, thank you. I'm glad to hear that there's a referral list that is better than the one that was initially available, which really wasn't a referral list. And one concern and something for leaders to know is for a civilian, if they go to a referral and they have to travel for it, and it's beyond the commuting distance, which is 50 miles, there is, of course, the time that takes, that the person will not be available. You know, they'll have to take sick leave, of course. So there's a sort of an impact on the mission there. There's also a provision in the JTR that they can be reimbursed. So there may well be a cost that some leaders are not anticipating that they should be aware of, may be headed their way. So it may in fact impact O&M dollars.
Okay.
A specific question, I guess, is similar to the prescription question, is I'm a little, I'll admit up front, I'm not super informed in this, but I understand that there are different shots for the progress of inoculations in Italy and the U.S. is not the same.
Correct.
So you have people who are midstream. So I'd ask that we get that addressed as well, so that everybody who's got a child under 18, it could potentially impact her. I don't know when the last shot.
You're talking about 14. Kiddos over the age of 2.
Even, right. I mean, I've got an 11-year-old who's going to have a 12-year shots at 12, and they may be very different. So I just want to make sure that we're getting proper information about but especially for the little ones.
Sure.
You know?
Yeah, and again, like I said earlier, we're going to address that. That's one of those specific groups that I do want to look at. We're also working through in our immunizations clinic. Again, that's one of our don't have an issue where we have to turn someone away. We're looking into what medical requirements there are for visit prior to immunization to get the immunizations. You're talking about 4 to 6 years, 11 to 13 years, those kinds of things. So that's something else we'll be looking into and putting back out to the community.
Okay, that will be helpful. And another thing is I have, I'm pretty good authority, my own, that the message to the liaisons at San Bortolo, maybe it's been clarified, but they have not received that they will not help. I was there personally, there was no beneficiary present, and we were told in no uncertain terms we can't help you. This has also happened to somebody else who came and told my wife about it. So I would ask you to re-energize that, because that message is apparently, from what I've been told, not getting to the liaisons at San Bortolo.
Okay.
Because there's still, some of them are under the impression that and I see head shaking, and it's more than 1 or 2 antidotes that I've been told. I can only speak of one.
So
but-
starting from right now, if anyone in the community it runs into that problem again, I would ask you to put in a nice comment card or come see me over in the health center and make me aware of it. I can tell you I've personally engaged the issue. I can tell you my DCCS has personally engaged the issue. My ClinOps chief has personally engaged the issue. So there should be no doubt in the minds of those over at San Bortolo or inside the health center what the message is. The message is we take care of civilians, comma, when space is available. So again, if I've got, and we take care of people before we take care of medical records. Okay, so again, kind of like I explained earlier, if I have a patient liaison who is not otherwise engaged with a TRICARE beneficiary, and I have a civilian that comes in and needs assistance in the emergency room, labor and delivery ward, inpatient ward, whatever that might be, we're going to take care of that patient. And so if that is not occurring, I need to know about that at my level. Okay. The other thing, just a caveat on that, Dr. Novak, who's one of our pediatricians who does rounds down at San Bortolo every morning, Monday through Friday, will continue doing rounds on every single American that's down there that we are allowed to provide care for. We can't provide care for tourists. But if you are on the list of availability to come in and receive care at the health center, we will provide that rounding service for you in the mornings.
Okay. And then the last is a comment that I don't want it to sound disrespectful. It's not intended to be so. But the sense of people who have come to me, who I've talked to about the call-in at that hour, is that it's a de facto you can't be seen. Because the practical matter is, much like the teacher mentioned that example of for a full week they called and couldn't get in. Since it's been almost a year that they started the Space A call-in with the adjusted time I forget now because my wife usually does, I wish she were here, it's at 7 or whatever, 7:30, whatever that call-in time. If you called in even 30 or 45 minutes after that time, nothing doing, you are not going to get in. So the sense is, I just want to share with you, is you may think that it's, hey, I'm doing this out of the goodness of my heart, or it's being viewed with cynicism. It's like, just come out and tell us you can't be seen, because it is a de facto you can't be seen. So I just want to share that with you. And again, I don't mean to be disrespectful,
No.
but that is a consensus
Sure.
of the community. And it seems to be the reality. So
Okay.
just want to share that.
Well, I appreciate you bringing that up. I don't take any disrespect from that. Actually, since we've put our new call-in time in place, the last couple of days, I think we've filled our last appointment at 13:45. Both in our red clinic and in our white clinic peds and primary care. So again, there will be days based on our provider availability and based on what we have left over that you're not going to be able to get in. I think as we continue calling forward and as we've again tried to fix the templating and availability issues on our side, I think you will find appointments available at that time. And again, we will keep auditing it. This is very, very important to me. We're not going to say we don't take care of you, because we do take care of you if I have space, and I need to make sure that I've got appointments to do that. Yes, ma'am.
You had mentioned earlier that people who have chronic ongoing conditions would be contacted. Well, because there wasn't any notification, some of us who have these chronic conditions take medications that we need filled, and we can't get them filled.
Okay.
How is that going to be handled? I can't wait, 2 months to get something I need in 2 weeks.
Right.
Is there any ability to resolve that?
Yeah, see me after for your individual issue.
Okay.
From the community's perspective, again, because Space A civilians are not enrolled, I can't just go punch up a list out of our data systems and say, oh, here are the 500 or 300 or whatever it is patients that need chronic care. And so it is going to take us a little bit of time to get that information together. I'll talk this through with my staff, and we'll put something else out on Facebook for that particular issue on how y'all can call if you're going to be running out of meds here in the next 2 weeks.
Right.
Okay?
Okay.
Thanks. Yes,
Sir,
ma'am.
I have some of the Facebook questions.
Okay.
I thought we could go ahead and maybe address some of these so they might answer some questions that other people
Sure.
might have. I'm going to reiterate earlier, there's a question on here that local doctors will not accept private insurance that civilians might carry. It's not going to happen.
Right.
Okay.
And that's again, I think that's been going on in the community for a long time. That actually came up at our birthing center town hall, where one of our community members brought up that, you know, even if you're going into the hospital, you have to pay up front for your copays and this and that. So again, because we are, if you look at us as a TRICARE insurance clinic, anyone without TRICARE insurance, unfortunately, those issues are between you and your insurance company. And I do believe, due to past practices, basically the providers and hospitals in this area have said, hey, we're not taking insurance and we are taking payment up front. The other issue with that is I don't know a ton about the Italian healthcare system, but I do know that insurance is really not part of it. And so they don't have the system in place where you would normally go to the downtown community hospital in San Antonio, Texas, and say, here's my Blue Cross Blue Shield card. They have no system in place to even process that. So I do realize that that's an inconvenience for our community, but that's where we live.
Okay. There's a question about retiree TRICARE Plus patients having to pay for services up front at San Bortolo.
Okay, so the differences between TRICARE Prime and TRICARE Plus. What TRICARE Plus is it is basically an outpatient benefit that whatever facility, not even an outpatient benefit, it's a medical benefit that as a retiree, if you enroll in TRICARE Plus, you can receive whatever services that MTF offers. So if you're in Vicenza, you can receive, you know, primary care, behavioral health, physical therapy, pharmacy, lab, x-ray. If you were in the Launchstool area and went TRICARE Plus, then you've got full access to inpatient health care, procedural issues, and all that kind of thing. So anything that we can't do inside the MTF, the TRICARE Plus beneficiary, when they go outside the MTF, is actually on their own with their other insurance. And so to the point that we don't even put in referrals for TRICARE Plus patients to go see a specialist, because that's not a TRICARE benefit for TRICARE Plus. But again, from a daily access perspective and a chronic care management perspective, if you qualify for TRICARE Plus, it's probably in your interest to enroll at the health center.
Okay. This was directed toward the garrison commander, but the question is, what's going to be done to reverse the reduction in services at the clinic?
Well, again, there's not a reduction in services at the clinic. So other than the birthing center issue that we discussed months ago that is going away, the health center will continue forward with the 9 providers that we have to take care of all of the missions that we have. So I have 4 pediatricians. I will still have 4 pediatricians. One of those pediatricians serves as a service chief and spends about half time seeing patients. Dr. Novak is the other, spends another half time seeing patients. Then I have 2 full-time pediatricians. So those 3 pediatricians, basically, the workload that they get just from our TRICARE beneficiaries is what dictates how much space A care we have. The same thing goes for my RED team, my primary care team, 4 family physicians and 1 internal medicine doc. And so again, the availability I have with them is what dictates the daily care. So it's really not a reduction in services. It's just that where we might have had more availability to guarantee care for you going longitudinally, I now have the same amount of providers that I had a year ago, but now I have many more TRICARE beneficiaries here that I have to take care of. And that's what's causing the space A availability to go down.
Okay, last question. It's kind of complicated. It says, do you feel that adding the caveat of protocols with liaisons impacting the level of care at the hospital, if liaisons see patients according to the level of priority, won't doctors help those with liaisons prior to the space available patients? And what about the tracking of patients once they arrive? If there's no liaison to help immediately, how will they know a space available patient is in the hospital?
Okay. So the first part of that, the way doctors work in an emergency room, doctors work on a medical need triage system. So regardless of what language you speak, if you come in with a heart attack and there's no patient liaison with you, and you come in with a cut on your arm and there is a patient liaison with you, they're going to take care of the heart attack first. San Bortolo has translation services outside of our patient liaisons. They are, I believe, required by law to have a language translation service that they can call if they need to. Many times, from what I understand, the provider and the patient and whatever family member or support is there have those conversations to be able to direct that care. But if there is not a patient liaison available for you, I believe you can ask them to activate the translation line so that you have someone on the other side of the line speaking English and translating in Italian. I can confirm that with San Bortolo, but that's what I've been told in the past. The tracking of patients as they come into San Bortolo is an issue we still have a little bit of tweaking to do. But again, every morning, and actually every shift, the patient liaisons are sensing the hospital to see who is there. So what I would recommend to the community is if you find yourself in the emergency room and a patient liaison can't get there, after the workup, and if you have to be admitted, still call that patient liaison later and just say, hey, I'm in the hospital. I know you couldn't come down earlier, but I'm here, and they will get up to you as they can.
Okay, that's it from Facebook.
All
Thank
right.
you.
Thanks.
Hi, Colonel.
Afternoon.
Just like to go back and let you know how poorly handled the rollout of this change was done by your office. You know, when we make future changes, I would ask that you handle it a little bit better. I was informed when I tried to make an appointment for my 3-month-old son that didn't I check Facebook and see the change? Can't see me anymore. So in the future, as we continue, would ask that emails like on Friday, that was very welcome. So put out the information a little bit through more official channels. I'd really appreciate that. I appreciate the list of English-speaking doctors, but just because the doctor speaks English doesn't mean the person on the phone making the appointment speaks English. So there's a barrier right there. So please take that into consideration. It's good to hear about the patient liaison. This isn't Germany. My wife gave birth down at St. Bartolo. For 5 days we were down there, and we encountered 2 medical professionals that actually spoke English through that entire time. So, in Germany, it's a different story.
Sure.
Italy, English isn't so, I guess, prevalent. Thanks. And then the final thing I would ask is, could you please explain to me why a retired military person that chose to retire in Italy has preference over me at your med clinic, who I'm currently a civilian for the Department of Army?
Right. Well, first of all, I appreciate your comments again that you started off with. The way this thing was rolled out was completely my responsibility. We felt that getting Facebook notification out there would be the fastest way to do that, and we certainly probably missed some folks. So again, I take responsibility for that. I normally do not like to make changes like that, and again, when I find out that my TRICARE beneficiaries cannot get in, I have to take rapid action, and that's what I did. Like we've done with the birthing center and like we've done with other things that we've had to do at the clinic, I do like to roll that out in a much better fashion and get input from the community and be able to engage like this and take care of those issues. But I do appreciate your comments on that. Why retirees have priority over DODEA teachers is a TRICARE management activity, very senior level strategic decision. It has nothing to do with me or Launchstool or European Regional Medical Command or the Surgeon General. It has to do with the way TRICARE insurance works and the priority of care. So I don't really have a great answer for you. I do know that all GS civilians, before they come over, and again, I understand it's hit and miss with some places, but I believe there is something that has to be signed saying, I realize I am not guaranteed health care at a local military treatment facility, and therefore
I don't
you have
recall.
to... Okay, so this is what I've been told. So again, I understand. I've heard that from some folks. I've not heard that from others. So again, there may be variance in the civil service side that, again, like I spoke about earlier, is a great issue for us to push up through the medical command over to wherever it needs to go and back down. I've already had discussions with the garrison about, hey, if we're going to have, if this is what reality is in our community, we need to get this information posted on the garrison webpage, on your webpage. We need to push it out through CPAC, and so we're going to do all of that. So, like I said, a bit of a learning experience the past week, but we have identified some good do-outs that we need to get engaged on and get that out appropriately. I have a feeling that even though that information is supposed to be out there, I would not be surprised if many civilians call ahead and have a list of questions like I do when I PCS, and they say, hey, how's the health care? I understand I may not be able to get seen, and I'm quite sure in the past it's been, oh, don't worry, clinic's got plenty of capacity, you'll get seen. So the problem is we no longer have that capacity. And so the word that needs to go out now is they're absolutely going to take care of you acutely on a space A basis, but when you get over here, you need to make sure that you've got established care with a PCM on the economy, and that's the way, have that as a fallback.
And I appreciate the measures that you're taking now. However, and I appreciate the urgency to take care of the TRICARE covered individuals. But, as we move forward, just would ask you make informed, conscious decisions and inform us before you make these decisions, because it impacts a lot of people.
Sure, and I appreciate that.
And give us some warning
I appreciate
rather
that.
than just as of today.
I appreciate that. Yeah,
I-
we will strive to do that. It's
Thanks for
not an
considering
urgency.
it, sir.
It's actually a requirement. I don't have an option to speed up or slow down who we're going to take care of. I am by law and regulation required to take care of TRICARE beneficiaries. And so when I found out that I've got TRICARE beneficiaries that are not getting in because we, the clinic, don't have the appropriate controls on how Space A access is being given out, I had to change that right then and there. So again, I apologize. I know that the way that came out hit some folks that weren't expecting it, and we did have some friction there, and for that, again, I apologize. And going forward, we'll try to figure out with Garrison, the best way to get that information out.
I do appreciate the steps
Yeah.
you're taking now. Thank you.
Thank you. Let me just answer one more question you had. So you had mentioned just about the front desk staff at some of the Italian doctors' offices may not speak English. And again, we are aware of that. On the sheet that we're going to be sending out, what you're going to see is the provider or the clinic's name. And if it's a clinic's name, the providers will be listed under it. There'll be their address and their phone number, what their business hours are. If the provider speaks English, so I think we do have one Italian-speaking provider on there in case we have civil servants who are married to an Italian that would like to go see somebody. We've got that there as well. But then also if the front desk speaks English, we have identified a couple, 3 clinics where we know that is the case. And I think as the Italian providers understand that more people may be coming to them, that would be a step that they would want to take to garner your medical care, if you will. So we're aware of that. Thank you.
Sir, I'm curious, on average, how many appointments do you have available at 11 a.m. each day?
That's a great question. So what I can tell you is that if I have everybody in the clinic, I should have between 15 and 17 appointments available for each of those providers. I'm typically only going to have at the most 8, probably 7. So without trying to show my ignorance of math right now and do that. One of the other issues that we've got going on is trying to ensure that we pull patients into today. So what's going on right now is we have an OPAC appointment, which is a book ahead up to 24 hours. And I have to ensure that I've got same day availability so I can take all the same day, do today's work today kind of thing, so I'm not jumping into tomorrow. In most military posts, access to care is about a 60-40 split between same day and chronic care. So same day versus book ahead. This community, very interestingly, is more in line with civilian trends, which is 70 to 80% wish to have a same day appointment. So we're in the process of getting our templates corrected for that. And that's an ongoing thing based on the season and that kind of thing. Once we get that corrected with the same day access, I think that we will have more appointments available at 11. To directly answer your question right now, I couldn't tell you. Again, some days we fill up at 8 o'clock. And what I'll say, I'll take the hit for that. That means I didn't have enough availability that day. And again, that's a challenge to me and my staff to make sure that we have enough clinical availability to not get in that position. Like
so
I said,
are you tracking that, I guess?
We are.
You're tracking
Yes,
how
ma'am.
many appointments you have every day
We are.
available at 11 a.m.?
We are.
But right now, you don't have an...
I don't have the data in front of me. I can tell you that yesterday we filled up at 13:45.
But filling up at 13:45 is far different than saying you have 1 or 2 specialty appointments left at 11 a.m. So I guess that's... My question is, as civilians, we have to have some certainty about... I already know where my family and I are headed, okay? Quite frankly, the uncertainty doesn't work. But I think it's fair for our civilian populace to have a bit more facts so that they can plan. And one, I guess, suggestion, have you considered a phone line, for example, that just has a recording at 8 a.m. starting? We have 0 Space A appointments available in pediatrics already. We know that. Don't wait for us. Don't wait 4 hours. Start making plans elsewhere. Is that...
I'll take that back. That's a great idea. I'll see if that's something that we can do. I would tell you that the issue becomes I can't guarantee you any care ever. That's kind of the whole point with this. So I may fill up at 11 o'clock every single day, but the reason I fill up is because it's with TRICARE beneficiaries that I have to take care of. Now, if we fill up because I have not made sure that I have enough doctors to take care of the community, that's on me. And again, like I said, those steps have been taken to ensure that we don't do that. But again, I can't. So when I say we haven't filled up until 13:45, that means there were a significant number of appointments available at 11 o'clock that if you had just called in for a same-day issue, you would have gotten one of those appointments.
Well, and that's news that needs to get out to the civilian community
Sure.
because my experience, quite frankly, has been similar to Stephen's in that if I call at 7:40 instead of 7:30 for my children who, quite frankly, their medical needs don't coincide with when appointments are available, there's a huge difference.
Sure.
So I suspect that you have very few appointments, but I don't know that because I don't have the facts. And so I'm asking the folks who have the facts to disseminate it to the rest of us so we can better plan.
Right. Well, two issues here. Again, I think that's why everybody establishing with an Italian PCM is a very, very important thing. So if the instability of what I'm going to be able to provide day to day doesn't fit into your particular family situation, and we do have good providers on the network that speak English, it takes one appointment to get in and see if you have that rapport with your provider and if you're going to be able to establish is it convenient for you where that office is, that kind of thing. Again, I highly encourage our Space A folks to do that just to see what that's going to be like. Because again, there will be days because of missions that come up. If I have to immediately pull 2 docs to go support a mission somewhere else due to a training mission or some other active duty mission that I have to do, and all of a sudden those appointments are gone, I may fill up at 8 o'clock that day. I may not fill up till 13:30 the next day. So it's very, very difficult to predict that day to day.
Hello, sir. My name is
afternoon.
Lorianne McKeever. I'm a retiree, 22 and a half years, and I am in TRICARE Plus. But I'm also a non-appropriated fund employee, Child Youth School Services, MWR for life. Had to plug in that ad there. I am the Child Youth School Services nurse. So what I deal with on a daily basis is immunizations, current immunizations. Registration of children coming from overseas or from CONUS, special needs accommodation issues. Those can be asthma, those can be wasp allergy, those could be diabetes. I did want to plug in that EFMP back in the day seemed like you really needed to get screened before you got an overseas assignment. And if you put yes on one little check mark, you were off those orders and somebody else was moving in. And it doesn't seem like that has been the trend since I've been here since 2005, just putting that out there. But our issue right now is when you say chronic and we have children with asthma, that's chronic.
Correct.
But how do I tell the children that belong to non-appropriated funds, Department of DODEA civilian employees, and contractors, I know your albuterol is expiring, or I know the prescription label is expiring, or I know the respiratory action plan is expiring. Go find someone to help you, because I can't now. Or there's a 7526-1 that is a health screening tool that all parents have to fill out before they get a pass to register their child in our programs, child development centers and SKIES and fun stuff that we do for life. But those documents then, depending on how that parent answers that for the ADHD and the asthma and the allergies, food allergies to be included, that information goes as a mini packet to the Army Public Health individuals at your clinic. And so right now the system is that the Army Public Health nurse, correct me if I'm wrong, gets to go into the medical record and see if that is uncontrolled asthma, blah, 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 or whatever, and they put their graces on this other document, and then we get it back at Parent Central, and if everything is all in order, the person gets a pass. Sorry. I'm talking a lot. But Now, if we send these people out on the economy, how does the Army Public Health nurse put that blessing for that child to receive care?
Right. What I would ask you to do is get together with my staff. We definitely need to sit down and look at what the requirements are and what our requirements are to help with your requirements, and we just need to have that conversation.
Okay.
Again, this is probably one of those groups that we haven't dived into.
Okay.
What does the future look like for kids that are over here that wouldn't be over here on EFMP but are over here because they're not EFMP'd, and how do we take care of that population? So if you'll get with probably Lieutenant Colonel Burnett, and we'll get some information back and
Sounds
forth
good.
and start diving into that.
Okay, thank you very much.
You bet.
Before you take the next question, let me grab a seat here. I'm not going to stay though.
No, you're welcome.
Can you hear me back there? I get a lot of questions from the garrison, and when this occurred, we don't own MedCom. I don't control what they do. You know, they've got a patient liaison. But make no mistake, we're very interested in how this is being handled. And so my point being is I stand side by side with Colonel Barr on this, in that what we can do to assist, whether it's communicating better, whether it's getting hold of the Army G1 and telling them you got to work EFMP better, or you got to tell people before you get on that plane to Vicenza, you know, look at me with both eyes. This is what you can expect on medical care, so you don't come over here with false expectations. And this is some of what I'm hearing. And then the health clinic doesn't meet up to that, and then you feel like, gee, I'm on my own. And we don't want that to happen. So we will do everything we can in our realm of authority, responsibility, and just plain community. And so from the garrison standpoint, it's one community, and we look at working this together so that we overcome this and we find some good solutions for you. Thanks for letting me talk.
You can stay up here if you want.
I don't mind.
Sorry. Yes, ma'am.
Good afternoon, sir. My name is Anita Fisher, work in the JAG office. I'm hearing some conflicting information. I just want to ask one piece of that. First, in your introductory remarks, you made mention that you had been looking at this for a while now, but then later on you talked about how you had to implement it right away. My understanding is that this has been examined for the previous 2 months. And so during that time, had you given any thought to how you're going to address this to the civilian populace? As Mr. Bruiser pointed out, Germany has a much more developed network. Have you given any thought or made any effort into negotiating with some of the Italian providers that can serve us and perhaps accept our insurance like they do in Germany? And granted, it's because Germany has a much bigger populace, but there's been a lot of negotiation with those host nation providers in order to accommodate the civilian workforce. And given that lead time, that my understanding that you had any of that been done, or have you given any thought to now doing some of that?
I'm not sure what lead time we're talking about. So there have been inklings into concerns with Space A, but certainly nothing that dictated that we had to do what we did a couple of weeks ago until a couple of weeks ago. So there are issues that go on over in the health center all the time that we look into to try to make sure that we are providing the best care to the community that we can. And so when those things aren't urgent, as someone said earlier, we have time to work through those. They became incredibly urgent 2 weeks ago, which is, again, why I did what I did. And again, I apologize for any issues that's brought about to our community. As far as the medical command negotiating with providers out on a network, if you will, there's absolutely nothing for us to do with that. They don't do that in Germany. You have folks that have TRICARE that come see us. You have folks that don't have TRICARE that we fit in as we can. And then you have folks without TRICARE that have their own insurance that then have to go out and find that care somewhere else. I'm not under any information that anyone at Landstuhl or at ERMC has coordinated with a clinic in Kaiserslautern or whatever to help take care of civilians. It's a great idea.
So the TRICARE approved providers in Germany, would that just be going through the TRICARE office here and getting them to perhaps look into whether there can
If I can understand, if you're talking about networks, so we have providers out in the local community, both in Vicenza, Verona, Padova, Milan, Udine, I mean, all over the place, that are in the TRICARE network. so that when a TRICARE beneficiary requires a referral to a rheumatologist, if you will, there's a list of rheumatologists in the area, and we send them to one of them, and then they have a contract with TRICARE to provide that care and then be reimbursed. Nothing like that exists for Space A patients that I'm aware of. Now, what you could do is, let's say you have Blue Cross Blue Shield or Humana or whatever you have, you should be able to go back to your insurance
And their
company
network.
and say, what is our network in this area? And then they would give you a list. The list that we're going to send out to you is basically just a, I'm seeing heads shaking.
They don't have a list. For most of our insurance companies, whoever we go to, they will pay the bill, so they do not provide names to us.
Really? That's interesting.
And the TRICARE list for pediatricians referred me to Udine.
Okay, yeah,
which,
so
I mean,
again,
that's a 4-hour.
again, apologize. Again, this has been a good learning process for us over in the health center. So the week has been very, very good. What we're going to be sending out to you today, there is nobody on that list outside of about a 20-minute drive from Vicenza. Most of those providers on that list are in Vicenza. We've got a couple that are just a little bit out, but it'll all be local. And again, that's a service we felt like we needed to provide. We're not required to provide that, but we felt like we needed to provide that to help our civilian staff find other accommodations to set up care. Yes, sir.
Afternoon, Colonel. I'm a DoD civilian, been here 3.5 years with my family, and I want to first say I really appreciate the services that the clinic has provided my whole family.
Thanks.
And because of that, my question in all seriousness is how can we, meaning the community and the command, get you more staff so this is no longer an issue?
That's a great question.
I'm just ignorant of how that works.
Yeah, there are, if anyone's following the news right now, I think we're all following the challenges that our country is having after being at war for over 10 years. The Army is reshaping itself. The Army is looking at very, very qualified junior officers, mid-level NCOs, probably senior officers here not before too long, and looking at how many of those folks we need in the Army to support a force size of X. And that's going to be a process over the next few years. So that's the personnel side of it. And then there's the whole money side of it, which is how much money do we need to support this size of force, and what is our mission going to be for the next 20 years, and how do we train, and how do we prepare to go downrange, and what's coming up over the hill. So these are significantly huge issues that are being dealt at very high levels in our government, and they unfortunately cascade down to the tactical level, which is where we all live down here. The other issue that we have in the MedCom is that we are solely resourced by the number of TRICARE beneficiaries we have. So I could have 7,500 TRICARE beneficiaries here and 15,000 civilians, and the clinic is only going to be staffed to those 7,500. Again, it is a strategic, it's a good conversation point, a philosophical conversation point for all of us to have and maybe push back up the chain. If we are all Americans living overseas, how do we take care of that population? And what is currently going on right now is that for the categories I've already talked about, that's taken care of here. For DODIA, it's taken care of here. For GS, it's taken care of here. And that's how it works now.
Now, I know the situation was caused due to the great increase in the number of TRICARE beneficiaries. Would that lead to you having additional staff? Because if it's based on the population of TRICARE beneficiaries?
No, because we've been, trying to look for the right word here. We've had plenty of providers here for a long, long time. I'm not sure how we got those providers here on the manning document that we have. I'm not sure how we had all these providers here if we didn't have the population to support them. I'm sure there were fluctuations over time, and the way it used to be, this is how we man the clinic. But again, going forward, at MedCom level, they are re-evaluating the formulas. One provider should be able to handle X number of beneficiaries. Those numbers are being re-looked at very high levels. So those things change all the time. So I would tell you that I have, really for all of my PCMs, I have capacity. I still have, for each of my PCMs, I probably have 100 or so slots. So part of this challenge with Space A Care is, well, if I have capacity, and nobody's booking out more than 7 days, really, why can I not provide same-day care? And that's a challenge for me as a commander to make sure that I get that fixed. And if I get that fixed, if we still have capacity, then again, Space A Care on a same-day basis should really not be an issue. I just can't guarantee that to you. That's the problem. So what I can do, again, as I've already kind of talked about, is go forward, make a commitment to you to let you know I'm going to do everything I can as a commander to ensure that I'm providing the maximum amount of care every day. Some days will be great, some days won't, but that's what I can at least promise you.
So beyond the same day space A, is there still space A for civilians to book appointments in the future? Say if they
No.
do have a child with chronic asthma.
Yeah, that's not,
or
because
something.
that then guarantees access, which I can't do. So
Okay.
again, it's a space A means space available. If I were to allow you to book an appointment 3 weeks out, but then I had 3 more requests for those 3 appointments and you've already taken one, then I've violated my TRICARE beneficiary standards again, so.
Okay.
Unfortunately.
Yeah, I mean, any way you could, I mean, I would be interested in knowing any way we could influence, helping get you additional staff, so that would be just information for I mean, the community to be interested in, obviously. And my last comment is, along with, I guess, a lot of other people, concern over the 11 a.m. call-in time. I'm glad to hear that you're re-examining that as you get, a better handle on the picture, because if that could be made earlier, that would be definitely helpful.
Yeah, I appreciate that. And again, we will continue to look at that. When we said 12:30, again, we were kind of in reaction mode, and it just didn't feel right, because I know if you call in at 12:30, especially for teachers, I mean, you're not going to be able to get over here in 2 hours, even if I have an appointment. So moving that back to the left, but again, guaranteeing access for TRICARE beneficiaries is the key, and we just have to find what that sweet spot is for the timing. Thank you.
Okay, so 3 things that I've thought about in sitting here. One is the whole thing that you just mentioned about teachers and not being able to get here. It's not just about needing to get a substitute to cover our class. That's one issue. But if I'm calling you from my classroom in front of 30 kids. So there's no privacy. So that's a huge issue, just so you know that.
Okay.
The second thing is when I came onto DODEA quite a long time ago, well, not as long as some others, I do remember going for my physical. I may have signed a paper that said I didn't come to Vicenza. My first duty station was not Vicenza. But you said, people need to look you in the eye and tell you. That doesn't happen in our directorates. You might need to start communicating that with other people, because we have 48 hours to accept our position. We don't have time to call and find out what's available on the other end. When they call and offer you, you have 48 hours to accept your position, and then you're within a month or less, you're gone. You're on your way there. So it's very different than what I experienced when my husband was active duty. It's a very different world. The third thing, so you might want to communicate or have someone communicate to the other directorates that are civilian directorates about those kinds of things. And I have a clarifying question I want to ask you. You said that there was no reduction in services except for the OB clinic, correct?
Well, the birthing center and same-day surgery and OB-GYN clinic will be going away in June. So
Okay,
everything else remains open
So I
as it
just
is
want to
now.
clarify this, because I do think it's important, and I'm not sure everyone has thought about this. Gynecological services are no longer available. So any gynecological service that would have been seen in the OB-GYN clinic will now be seen in primary care. Am I correct? So that eliminates appointments in primary care. You have eliminated service for a whole gender. You have eliminated care for a whole gender. And I think that's important for you to acknowledge.
Okay. Well, again, I wouldn't say that we're eliminating care. What I would say is that I can't provide chronic care for any group that's in this community. And again, I think it is very, very important for civilians to utilize their insurance benefit established with a primary care manager or a specialist of their choosing that can provide those services for them. So GS civilians have an insurance benefit. I am welcoming you into our health center to utilize the space available appointments we have available. If I have no space available, appointments available, I can't provide care for you no matter what gender you are.
I understand that, but you have eliminated specialized care for a whole gender. And what that means is that now all of the active duty soldiers, female soldiers who would have been seen at the OB-GYN clinic for gynecological services, now have to be seen through primary care. So those appointments will not be available. So you have to, it's kind of common sense. You have to say, yes, that's true. And it impacts everybody, not just the space A patients, because those patients can no longer be seen in the specialized care clinic that they need to be seen in.
Right. Well, I don't have, again, space available to provide that care like it's being provided now because it's going away. A normal patient panel for a family physician, of which I am one, is about 900 to 1,000 patients. And that is the number that the medical command has decided a family physician, full-time equivalent provider, can provide total care for. And that total care involves routine wellness for women, routine wellness for children, and it involves all of that. So again, our challenge as a command and as a health center is to ensure that for that patient panel, we can provide all of that care. For a Space A patient, I can't give you a PCM. And so therefore, I can't make that contract with you to provide your chronic care. And since you do have a health benefit that you can utilize, yes, all of the space available female gender patients that we have that we're seeing in a place that's closing are now going to have to go off onto the network. But that is not a decrease in services as I see it. That is you utilizing your healthcare benefit the appropriate way. I realize it's semantics, but it is the
I think
it
it
is the
impacts
constraints that I have
everybody,
as a
not just
commander.
us.
It's the constraints I have as a commander to again guarantee healthcare for my TRICARE beneficiaries. At the same time, I maximize healthcare for the entire community.
Right.
The specific instance you're talking about, I do not have the capability to provide that care anymore.
And I understand about the space available. I'm just pointing out that it does lead to a reduction in services, whether you want to or not, and
Okay.
admit it or not. And the other thing about that is that when we do use the clinic, or when civilians, because I'm a different category, but when they do use the clinic, their insurance does pay the clinic too. It's not free. It's not
Correct.
that they're coming there without making payment.
That's correct. So that's called third-party collections.
Right.
And certainly any time that we see a space available patient with third-party insurance, we have to bill them by regulation. And if I don't have an appointment to give you, I can't bill your insurance. So again, it is no question, it's not providing free care. You're getting billed. We understand that. But again, it all has to do with the availability of that care for me to offer in the first place is the issue. Thank you.
Good afternoon.
Good afternoon.
Today, we are principally dealing with a bad news story here. However, I think there is a potential good news or potential silver lining to this, but I think it's incumbent on the clinic to demonstrate this. And that potential silver lining or good news is that Italy has a strong health system. I think it's incumbent on the clinic, though, to give us that confidence, to show that the clinic is confident in its strength or at least the adequacy of the Italian health system. And part of doing that is also providing sufficient numbers of providers that we can go to, both pediatricians and general practitioners. I think it would have been better if you and your team had done this prior to the rollout. However, that doesn't mean you can't do it now and you can't still make up for those mistakes that may have been made. But I've been here since 2008. I'm very comfortable in the Italian health system. I speak Italian. My wife speaks Italian. My kids are half Italian. But most of our community is not in that category. And so we're going to continue to recruit quality civilians to come here. We need to give them confidence in that health system. And I think that you and your team are capable of doing that, and I think that you have an opportunity to do that. I just hope that now you'll take that opportunity.
Yeah, well, I appreciate your comments. I think we did that very well with the birthing center transition. I have extreme confidence in the Italian healthcare system. It's interesting when you look at two cultures and the differences between them, and you look at obesity rates and rates of health in Italy versus the U.S., how we access health care between the two cultures. I would tell you the Italian culture, from my perspective and observation, is a very healthy community. They're all born, they all live, they all see doctors, and they all have great lives. So I think that those opportunities are out there. I appreciate your comments. Again, I do apologize for the inconvenience that may have caused anyone, and we will certainly get the information out today or tomorrow that I talked about earlier. Thank you. Yes, sir.
Good afternoon, Colonel
Afternoon.
Barr. Thank you for making yourself available for this. I really have a question. It's more about the mechanics of how this is going to proceed now. I understand the policy is pushed on you. You just have to respond to it. On the mechanics side, as a DA civilian, if we had established a PCM here, as some of us had, what will the process be to transition to an Italian PCM? I mean, will we maintain a set of records here and then still send a set of records over to a Italian PCM?
Yeah, I've not worked through all of
Okay.
the specifics on that. Again, I have to gather that list from higher before I can start doing that. I think what it's going to entail, depending on your care, if I've provided you chronic care, there's probably chronic medical records that are involved in that, so I probably need to get you a copy of those. We need to look at your specific needs and figure out what providers in the network or out in the local community would best benefit you. Probably a conversation between you and your doctor that's treated you on, hey, do I get this care back home when I go home in the summer? Do I get this care if it's just once a year? Do I get this care routinely with an Italian provider, and who would that be? Talking through refills of medications, labs, or x-rays that you might need before that transition. So it's a little more complicated than that right now, and again, something we continue to work through, and we'll get that information out.
And you already spoke to translation services in terms of, okay, if we take our records over and we have to give it to an Italian, will our insurance provider work that out with them? Just would ask that we be kept up to date on what that process will be, or if it changes.
Sure.
And my last real question.
Let me just address that real quick. So again, for TRICARE beneficiaries, the TRICARE Overseas contract, since Sam Bordello and all of the doctors that we see in Vicenza are on that contract, that is supposed to go back to the contract and produce American records. I would assume that whatever insurance plan that you're on has a stipulation that, hey, if you're seen in Italy and you get your discharge summary from the hospital, they have a place to send that for translation. And if not, again, I would encourage everyone to get with their insurance companies and find out what that plan is. Unfortunately, we have absolutely no way of knowing for all of the different healthcare plans that are out there available to civilians, the nuances of each and every one of those. If I had time to do that, I'd be happy to look into putting that information out, but I don't even know how many insurance companies there are that offer programs to you all. So if you are admitted, what I would ask you to do through the patient liaisons, because again, the patient liaisons will not be busy 24/7. Yes. So if they know that you're in the hospital, you're about to be discharged, when Dr. Novak comes by and sees you, you might want to say, hey, I need to get a copy of my medical records. How do I do that? What we'll try to do is firm that up as well and get that posted to let you know what the process is. But in the meantime, that'd be the best way to do that.
And as this develops, obviously there'll be more questions. What will the process be to communicate those questions to you? Will we just call a standard number and say, hey, here's my next question?
I hate to throw Joe under the bus. You can always send those questions to the patient representative, Joe Penhaligon.
Okay.
You can post them on Facebook if they're not, of a personal or medical nature. We track that. You're more than welcome, if you're in the neighborhood, to bring them on by. Let us know what those are. Very, very similarly to when I talked about the birthing center, I am very, very interested and concerned with getting feedback from how both we and the community of medical providers out there provides care. Because although I may not be able to guarantee certain things to you, I can affect other things through other means. And so if something's not working for a group, the best folks to get a hold of for that is us. So we're out there kind of on Facebook in the ether as well, and we see these conversations going on sometimes. And sometimes my question is, gosh, why didn't they call the clinic, or why didn't they call the patient liaison after there's 27 Facebook posts? So we are your advocates. I can't guarantee you care in my health center every day, but what I can guarantee is advocacy and working through these issues that come up. We're here to take care of you in some form or fashion. So those things that come up for the entire community, if you can get those back to us, we'll look into them and try to help you out.
Excellent. Thank you.
Okay, thank you.
Ladies and gentlemen, we have time for one or two more comments before Colonel Barr gives his closing remarks.
Good afternoon. My name is Tamara Peruzza. I work with USAG G4. Now, I'm a DOD civilian, but I'm also Army Reserve. Okay, so sometimes there's a conflict in how my appointments are set up. But that being said, there needs to be more than just Facebook to put out information. I do not have a Facebook account. I have never wanted one. I have no desire to overshare. So when you're putting out information only on Facebook, people like me are getting left out of the loop.
Sure.
So something needs to be put on MedCom's website or whatever to say this is how these procedures are going to work, and not just depend on Facebook to do your work for you.
Right.
I
appreciate your comments, and again, I apologize for any issues that we've had with that. I think obviously as we move forward, any posts that we put on Facebook, you don't have to have an account to see that, it automatically goes to the Garrison Facebook page. And obviously with these kind of issues, we're going to be coordinating with Garrison to get that blast out to all the email for all the civilians that work on Garrison, USARAF side. So we'll get that taken care of.
Okay. The other thing too is that dealing only with the Italian healthcare providers, some of them, for example, I had to see a Italian healthcare provider that works actually in the health clinic. And when he's looking up medical terms on the same websites I'm going to find out what those words mean, I'm sorry, my confidence level isn't real high. Also, on the Italian system, for example, ADD and ADHD, the Italian system does not recognize those as diseases. So how are you going to take care of people like that?
Right. Yeah, again, that's one of those groups that we're looking at right now. We're formulating a plan on how we're going to do that. I don't know the entire number population that's out there right now that has that disorder, but we're going to take a look at that. Again, as far as dealing with Italian providers, again, I would ask you to look around until you find somebody that matches your expectations and that kind of thing. The Italian providers that I've been familiar with that speak English actually speak English very, very well. But of course, if you're not American, not English, you may not have the command of the English language, certainly that someone that speaks that natively does. So again, if there's a concern with how the provider's interacting with you or their ability to speak a language, I would probably not see them again, bring those concerns up, and then find another provider that can connect with you a little better.
All right.
Okay.
Thank you.
Thank you. Buonasera.
Hi.
Is it buonasera yet? It's buongiorno
No,
still.
not
isn't it?
yet.
Oh, all right.
Hi, for people who don't know me, I'm Eva Piacentile. I'm MD, DDS. I have a dental office in Padua. I'm on a TRICARE list for the dental clinic. And it's about 20 kilometers from Padua, but a lot of Americans drive because they want to have somebody that can understand them and be sure that they understand it. The understanding has to work both ways, not only hello, how are you, good morning, sit down, and that's it. When they had the inspection a few years ago from the TRICARE from Germany, the doctor who came, he checked all the offices in Vicenza, and then he kept me for the last on the list. He came to Padua, and he said, you're the only one who can understand, and one can have a regular conversation with you. In Vicenza, there are not too many doctors that speak English, at least as a dental part, very, very few. Years ago, I've been here for 30 years. My late husband, he was the one who was active in signing the agreement with San Bortolo. 25 years ago, when they signed it, San Bortolo was supposed to provide English-speaking doctors and nurses, which didn't happen. My daughter, for example, she's a physician. She speaks very good English. She got a contract at San Bortolo for free for 6 months, and they couldn't get her a contract to work because we're not political. And if you don't reinforce it, and if you don't use all your power you have, they're not going to hire English-speaking doctors, which doesn't mean they don't have. In Padua, there's a lot of doctors that speak English, a lot of US-trained doctors, and they have very good positions. For the case like Mayo Clinic, if you want, I can help you to find a doctor in Padua, which will be much better because they have better connection being a university hospital. San Bortolo is a very good hospital. It's the only answer for you because it's right here in Vicenza. But I know there are American physicians in Vicenza, in Padua area. And it was something that I was even talking to Colonel Burnett some time ago, that I would suggest, if it would be possible, to organize an office with American doctors. They're all doctors. They have, let's say, license to practice in Italy, which legally it could be. They all speak English. They're family practice. They're pediatricians. It's something that probably now that you are forced to do something, it can be done. If you like me, I'll be willing to help. I always helped. I've been here for 30 years. So if you think maybe that would be a possibility, or if you give space, I can organize you all good speaking or all American doctors in the clinic after hours. I work from 5 to 9, 2-3 times a week for Americans. When they finish their job here, they have time to drive to Padua, and they do it. So it means the possibility of having a good communication is really basic, especially for people that retired here, and as they get older, they always come back. Even if they speak Italian, they come back to the first language, and they prefer having an American doctor and not Italian. The difference between American medicine and Italian medicine, they're two different worlds. I'm glad you have the confidence with the Italian system. I do too. But anytime anything happened to me, I was always on the plane, Landstuhl or US. The only time I had surgery in Padua, after that, my daughter said, "Don't ask me. I know I won't bring you here anymore."
Well,
So,
we
you know.
are, I appreciate your comments. I think that there are some excellent opportunities out there for Italian providers to band together and provide services to a population that is going to need those. So I encourage you and your Italian colleagues to do whatever you feel you need to do to provide that care. I have every confidence in San Bortolo. I have every confidence in the 2 university hospitals that are around here. We have absolutely no concerns through our TRICARE contractor of any quality issues, and we audit our folks who are in hospital here to make sure that that care that's being provided is being provided well. So I appreciate your comments. Thank you.
Hi, thank you. I'll be quick. One thing that came up in our office was the early return of dependents, both for military and civilians. I don't know that we have a CPAC representative in the room, but that's a question that we'd like to come back to. If it's possible for military members and civilians, I know it's always possible, but also curtailing of assignments. We have some people that choose not to deal with it, that want to curtail their assignment, and just to get the command support in doing that. So
But-
something else that
I'm
is
sorry, I'm
come
not
up.
following you then.
Okay.
ERD because of the medical situation?
Correct.
Okay.
Correct.
Haven't tracked that as an issue, but if CPAC, we'll get a hold of CPAC and support however we can. I'll talk to Chuck and Garrison about that.
We see a lot of, can you hear me back there? We see a lot of ERDs on a regular basis for various reasons, and every once in a while a medical one comes up. So I will just tell you, I was actually thinking the same thing when all this popped last week, and I think it has to be a case-by-case basis. It goes through the normal procedure where you convince your supervisor that your medical condition and the current situation is just of such a matter that you probably have to get an ERD. I will tell you, I would look in many cases to the Deputy Chief for Clinical Services to render an opinion in some of those cases that your situation is of such a nature that we need to ERD you back, because to get you over here costs a lot of money, and there's a huge fiscal responsibility, and so we don't treat ERDs lightly, and we look at every one, again, it's a great question, look at every one on a case-by-case basis.
And sir, if you want to stay up there, you might be able to help with this one too. A statement for our new employees that are coming. We've extended offers to several new employees. At the time, we've said, you can provide space A, clinic, really good. Is there a blanket statement that we can now provide them saying that you
For a
may
layman
want
like me to tell them,
reconsider,
you need to tell them
be aware?
medical care isn't what it used to be. Not just Italy, but the whole of Europe is changing, and if you have a chronic condition, you better take a serious look at coming over here, because again, as Colonel Barr said, if you've got serious medical problems and you've got a chronic condition, and I'm speaking like a layman, I would tell anybody, reconsider coming over here, particularly if you are under a lot of health care back in the States and seeing a doctor regularly. You're welcome to come. Again, it goes back into my look at my eyes with both eyes wide open coming over here, that you may have to go on the economy. And I would definitely tell them that. That would be my first message going out. I'll be working towards seeing how we can message this better, also with the Dodds and Dodea and that whole system, because my concern is, once you come on the plane, I want to make sure you understand what's over here and that you have a good time and you have a productive time, but that you absolutely understand how the situation is. I appreciate the chance to comment on that. Those are both good questions.
Thank you. One other question, as far as I know, I have to go out on the economy. I have to pay out of pocket for doctor's visits. My insurance will reimburse me, great. But is there any standard or idea of what I'm going to have to pay? And is there any standard or agreement with the listed providers saying that, well, I hate to use this example, but they won't charge us what they charge us for rent? You know, and no disrespect, but is there some type of, I can go into the appointment expecting to take 20 euro or 200 euro?
Yeah, I don't have that information right now. I can talk with my clinical operations staff and referral management to see if we can get that information. But yeah, there would be no negotiation on it from us, but we can see if we can get that information for a routine visit, for
Right.
whatever. We'll see if we can get that.
And providers lists are going to be disseminated, I guess, now through email and Facebook.
We're going to coordinate with the garrison on that to get that out in the best manner. We'll send that out either today or tomorrow. So however long that takes, it should be within the next week that we should have that out, I think.
And also, sir, I don't know if Army Community Services has thought about interpreters or a list of interpreters in case we cannot get an appointment with those providers that are identified English speakers. If we have to personally procure an interpreter, is that some type of service that we can go ahead and maybe get a list of people who are interested in doing that?
Good point. Let me look at that. I'm not going to comment too much now, but I think there's a lot of people that might freelance interpret, and that's something we might even look at.
Now, I don't know if there's Italian law that they have to be medical interpreters as opposed to just interpreters, but we don't want to get anyone in trouble either. So something else to think about.
Good
Okay,
question.
thank you.
Thanks very much.
Ladies and gentlemen, thank you for comments. Final comment here with Ms.
Okay.
Lucas.
Julie, I think just one.
Oh, yes, sir. Okay, this is from Facebook, and it's with a question with the OBGYN. They're not going to be moved to PCM.
No.
Okay, so say that a person has chronic issues, perhaps their medical records would be transferred to their PCM on that if they're a soldier. If they're a soldier.
I'm not following the question.
If there's a
I guess.
soldier that has chronic issues that they've been seeing somebody in the OBGYN, will their records be transferred to their PCM on that?
Well, if they're active duty, we've got their record. It's in Alta, so it's in the system. So they would transfer back to their primary care manager. If it's something the primary care manager could handle, they'll do that. If they need to refer them out to specialty care, then they'll do that inside the network.
Okay.
Yep.
That's it.
Thanks.
Thank you.
All right, sir. Chuck, thanks. Appreciate that. All right. Okay, again, I just want to thank everybody for showing up. I appreciate the sensitivity of the issue, and I appreciate the honest feedback and conversation here. I would just like to close with just saying we're going to do absolutely everything we can for the community within the constraints that we have, and we're going to try to figure out how to provide the best service for the most people that we can. So again, I appreciate your time today, and thanks for your support.
So unless you've been in a cave or under a rock, you've probably heard about Facebook, YouTube, or Twitter. The world of social media is growing, and it's a great tool for sharing or receiving information. But with anything new, there are some good things and some really stupid things being done. So Jess and I have come up with a top 10 list of the stupid things done in social media.
Number 10, posting an inappropriate or stupid picture on Facebook.
Yes, people post pictures like this and much, much worse. Don't be that guy